No, that's a lab. It won't be here by the end of the day. They'll be fine. Nope. Okay, Jacob, I need you to, I'm using a Bluetooth. I need you to give me some indication you can hear me.
Yeah, I can hear you.
Okay, cool. If you end up having a question, I won't see your chat because I can hear you. Why don't you just go ahead and speak up and say something? I will probably hear you, and then that will help with all that.
Okay, sounds good.
Okay, let's see here. Okay. Is this coming through the speakers at all, or no? No. No. Can you hear me now? Now is it coming through? No. Then it's not going to come through. Okay, gang, let's go ahead and start again. Skeleton crew, but that's okay. Let me make sure that, okay, so we're using, okay. All right, this Bluetooth should record regardless of where I am in the room. So when you listen to the YouTube video, regardless of where I walk, you should be able to hear it. All things considered equal. All right, let's begin. We're going to start with the adrenal gland. And the adrenal gland in the cat is off the kidney and towards the midline. In the human, the adrenal gland sits right on top of the kidney. It derives from the same mesodermic, adrenal mesoderm, but it just sits on top of the kidney. So they're both from intermediate mesoderm, the kidney and the adrenal gland, at least the cortex of the adrenal gland. In the human, they sit on top of the kidney like that little Dutch hat you see in the little girls with the wooden shoes. In Dutch, it's called a muts, a Napius muts, and it looks like a little Napius muts on top of the kidney. And I don't know if that means anything to any of you Dutch folk out there, but that's what it's called. Now you'll notice that the adrenal gland has two layers. So there is an outer cortex. Cortex is derived from mesoderm, and an inner medulla. This is derived from nerve cells. And it has a very neural look to it. This cortex has a very glandular look to it. And it is controlled hormonally. The medulla is controlled neurally. It's controlled by the sympathetic nervous system. There are no parasympathetic inputs to the medulla, just sympathetic. So this will secrete catecholamines, epinephrine, norepinephrine. Secretes epinephrine in about a 4:1 ratio. Let's concern ourselves now with the cortex, since that's the part that's controlled hormonally. So the anterior pituitary is going to secrete peptide hormone, adrenal corticotropic hormone. That's one of the trophic hormones made by the anterior pituitary. And it will then signal to the cortex. The cortex is organized into these 3 layers. So there is the let's start with the outermost layer. That is the zona glomerulosa. ACTH is going to do most of its signaling here. It'll signal other layers, but that's kind of where it makes its presence first known, shall we say. Second layer is the zona fasciculata. And the third layer, innermost layer, is the zona reticulosa, or reticulums. Each of these are going to play a specific role in the signaling done by the adrenal cortex. So the first thing ACTH does is it binds to all 3 receptors and all 3 layers, and it causes these cells to take up cholesterol from the blood. So let's do, I have some nice red. This will be our nice red blood vessel here. Kind of a blood vessel on drugs there. But it's going to take up cholesterol. And if it's derived from cholesterol, what that tell you? That tells you these are steroid hormones. All steroid hormones are made from cholesterol, all of them. Okay, ACTH also stimulates an enzyme called cholesterol desmolase. Cholesterol desmolase. And cholesterol desmolase is going to convert cholesterol to pregnenolone. Pregnenolone. So and let's just say CD, that's not compact disc, that's cholesterol desmolase, converts it to pregnenolone. Now, why is this significant? It's significant because this is the precursor for all the adrenal hormones. This is activated by ACTH. So ACTH does a lot of things in the adrenal cortex. Stimulates uptake of cholesterol, stimulates cholesterol desmolase. Okay, you with me so far? All right, now, many steps later, this pregnenolone gets converted to progesterone in both males and females, and then will get converted into a hormone called aldosterone. And that is in the zona glomerulosa. Now, aldosterone is a hormone that's going to regulate salt balance in the body. All right, so far so good. Now, this pregnenolone, does it just stay in the zona glomerulosa? No, it doesn't. No, it doesn't. And the pregnenolone can use, and so can some of the other precursors along here, are then used to make another steroid hormone, and this is cortisol. And that is made in zona vesiculata. Zona vesiculata, which you can see here, pretty thick. And this is a member of a group of steroid hormones made by the adrenal cortex of the glucocorticoids. And the steroid hormone aldosterone is a member of the so-called mineralocorticoids. And these names, I think, pretty appropriately tell you what they do. Mineralocorticoids regulate salt, sodium, potassium concentrations, minerals, if you will. Glucocorticoids, what do you think they regulate? Sugar, energy, that sort of thing. They do more than that, but yeah. Now, what about our friend all the way down here at the bottom, the zona reticularis? Well, the zona reticularis uses precursors from synthesis to make sex steroids, in particular, dihydroeandrosterone. So there's a androgen. And that's made in the zona reticuli.
What does that stand for again?
I better just write out because it's dihydroepiandrosterone, which is a male sex steroid made in both males and females. It helps with muscle development and bone development and all that sort of thing. So the adrenal cortex has to be stimulated by ACTH. That's very, very important. That is the main way you stimulate this. Now, aldosterone, as we're going to see, is actually controlled by another mechanism that we'll get to when we talk about the kidney. But its synthesis requires ACTH. Now, let's think about this from a clinical perspective, because this is actually kind of interesting. If we have a tumor here, and it's giving us too much of these adrenal hormones, how do you distinguish between a tumor in the pituitary and a tumor in the kidney? Now, of course, you could say, well, you could do imaging or something like that. Yeah, you can. But sometimes tumors can be hard to spot. Is there a physiological way you could detect one over the other? And if you think about it, we could sit here and stare at each other and have a staring contest and think about these things probably for the rest of the period. We wouldn't get much work done, but I suppose it'd be fun. Think of if you gave someone ACTH. You gave someone ACTH, would their tumor respond to the ACTH and make more of it? Yeah, it probably would. Whereas if you have a pituitary tumor kicking out too much ACTH, you probably have too much ACTH, so adding more probably wouldn't cause it to respond more. That'd be one way to tell whether your tumor is in the pituitary or your tumor is in the adrenal cortex. And that is called an ACTH response test that you can do to determine where the problem is in terms of endocrinology. All right, so this summarizes what I, in a tortured way, tried to tell you on the board. But you can see here, you make pregnenolone. What's the enzyme here? Compact disc? Cholesterol desmolase. Say it. Cholesterol desmolase. Jacob, say it. Cholesterol desmolase.
Cholesterol desmolase.
Thank you, brother. Well done. John, you're not off the hook either. Just say it, whisper it to yourself several times, okay? And you could say the pregnenolone is able to diffuse to the zona fasciculata. We can also see that these precursors are then used to make the androgens, the major one of which is DHEA and androstenedione. Those of you who are baseball enthusiasts, hint, hint, you two online, Mark McGwire, when he hit as many home runs as he did, it turns out he was juicing with androstenedione. Now then, it wasn't illegal. Testosterone was, but androstenedione was. Does it give you as much bang for your buck as testosterone? No, it doesn't. And so people argued that what McGwire juiced with actually should be legal. Others saw it a different way. I think you have to say this is going to give you a boost. It's an androgen. Is it as powerful as testosterone? No, but it's still juicing. It's still juicing, and what have you. All right. Questions on any or all of this? No? If you hypersecrete the glucocorticoids, the corticosteroids, so if we look at these, we could see we have corticosterone, corticosterone, cortisol, corticosterone. These are glucocorticoids and what have you. And if you hypersecrete those, you have a condition called Cushing syndrome. Cushing syndrome. Now, you may not necessarily have a tumor that causes this. Your cortex may simply oversecrete it, or you may be taking drugs that mimic glucocorticoids, like prednisone. Take large amounts of prednisone. That can actually induce artificially. That's called secondary Cushing syndrome. This will cause profound changes in both carbohydrate and protein metabolism. And you'll have hyperglycemia and hypertension and muscle weakness. And you'll have changes in your behavior and your personality and your memory and things like that. Your immunity will be lower. You'll store more body fat. You'll get what's called the buffalo hump right here. A big fat deposition will actually cause you to hunch over a little bit. You'll get what's called a moon phase because of fat deposition underneath the chin. And also you're storing a lot more liquid too. So your tissue, if you punch at the tissue, you'll have what's called pitting edema because of the storing of it and what have you. And people with Cushing syndrome can be really quite miserable because of this. Also, Cushing syndrome can be caused by oversecretion of ACTH. ACTH, remember, signals you to produce the glucocorticoids. And that will also contribute to Cushing syndrome as well. What if you don't make adequate amounts of glucocorticoids? Now you have a condition called Addison's disease. Addison's disease. In this case, you have poor electrolyte balance. So you have hypotension. You'll tend to have rapid weight loss, generalized weakness, dehydration, hypoglycemia, salt imbalances, profound salt imbalances. This can be treated by taking oral steroids. In fact, John Fitzgerald Kennedy, our president in the 60s, had very bad Addison's disease. And at that time, the dosing of the steroids was not well worked out. But he was able to live. But if you read some of the more recent biographies of Kennedy, the press always presented him as a model of health, when in fact, off camera, he was a wreck, an absolute wreck. And had he not been assassinated, some of his doctors predicted he might not have survived longer his presidency, if he even survived his presidency.
Was that part of the reason why he had a lot of back issues?
Yeah.
Or was that something else?
No, that was largely due to his Addison's disease. So let's talk a little bit about what these hormones do. So aldosterone is going to bind to receptors in cells found in the kidney tubules, in particular the distal tubules, or the distal collecting duct tubules, and the collecting duct. It will bind to receptors, and again, these are steroids. They go right through the membrane, bind to receptors in the cell. Those receptors then become transcription factors. They are going to increase the expression of the sodium-potassium ion pump on the basolateral side of those cells. So if you have, say, a tubule cell like this, And if this is the apical side, so the urine filtrate goes here, the basolateral side is here, and your blood vessel is here. Let's just say BV, blood vessel. And the pumps will be put in here. These numbers are increased thanks to aldosterone. These will drive potassium from the blood into the cells, and there they will be excreted then into urine. So potassium in the blood will then be excreted into the urine. So this will cause the excretion of potassium into the urine. The excretion of potassium into the urine. At the same time, it's going to drive sodium from the filtrate back into the bloodstream. So it will drive the exchange of sodium for potassium. What about cortisol? Cortisol's main job is to increase blood glucose levels. And it does this by promoting gluconeogenesis in the liver. Dave, now can you tell me what gluconeogenesis is? Very good. Creating glucose, exactly right. So you take essentially glycolysis, you more or less, with a few bypasses, you run that process in reverse and you make glucose. So you form glucose from non-carbohydrate sources, things like amino acids and things like that. Cortisol also promotes the breakdown of proteins into amino acids from muscle. It also causes a breakdown of fats into free fatty acids. These will provide the liver with more material to work with. Cortisol is necessary for fast energy, therefore. So let's say you're being chased by a band of raccoons. Your stress level goes up, you'll make more cortisol. Cortisol is a stress hormone. Cortisol will make your blood vessels more responsive to epinephrine. So you get vasoconstriction peripherally, vasodilation centrally, and you'll get more fast glucose for muscles to work on. The adrenal glands also will make some estrogen and some progesterone and some testosterone, but the amount they make is tiny in comparison to the gonads. So their contribution is minimal. However, secondary sex characteristics in women, like the growth of pubic hair and underarm hair, are both due to androgens made by the zona reticulans. Any questions about what's made by the cortex? Guys, any questions? Go ahead, ask them now. If not,
No, I don't have any, I don't have any questions, but can you have like Jacob take a photo of the blackboard behind you? So I can-
Oh, they just asked me, Jacob, if you could picture of the blackboard.
Yeah, I can do that.
Yeah, okay. So I won't erase it until you've taken a picture.
All right, thank you.
Yeah, I can do that. Yeah, he'll do that. He's got his phone out, and he's going to do that. All right. What about the medulla? The medulla, and then here I'll flip it around. The medulla make catecholamines, and the two that it makes are epinephrine and norepinephrine. And it makes them in about a 4-to-1 ratio. And your alpha-1 receptors in your peripheral circulation are much sensitive to epinephrine than they are to norepinephrine. This is the reason why if you go in for a job interview and you're really, really nervous, let's say Jessica goes in for medical school interview and she feels her heart beating and she may even look a little flushed because she's so nervous. That is actually epinephrine, norepinephrine that's been dumped into her system by her adrenal medulla. That's why she may talk faster than she usually does. That's why she may seem a bit up. She may start to shake even to some extent. And that's why in interviews, you need to do things like take water in with you. Holding something will tend to calm you down. It'll tend to keep you from shaking. The water itself, the cooling effects of the water will tend to help you calm down and what have you. So these are all tricks that you learn with interviews. For those of you who do those interviews and what have you. So again, this is not controlled by the pituitary. Very important to understand that. This is controlled by the sympathetic nervous system. And this is all part of the fight or flight response. All right, we good? Because this video doesn't play, so I'm going to now move on to the other of our videos. And let's talk about the thyroid, shall we? Your thyroid is located just below the larynx. It has 2 lobes, and if you take your thumbs and connect them like this, that's about what the thyroid looks like. Best guesstimate there. So 2 thumbs. The connection is called the isthmus. It's the largest of the endocrine glands. And I don't know if any of you got the opportunity to see the thyroid in your cat. That was a pleasure denied, all of you. The cat thyroid is actually quite human looking in many ways, but it's, oh, the glare on that is just awful. Yeah, is that better? So it has its own blood supply that you can see. These are usually branches off the carotid. The blood supply and then the veins are going to empty usually into the subclavian or thereabouts. It's different on the left and right side. But the thyroid, as you can see, in fact, this cartilage that's composes the larynx is called the thyroid cartilage because the thyroid sits across it. Now, when you go to your dentist and the dentist rolls you back and she starts feeling here, one of the things she's feeling is she's looking for a hard spot. Because when you're going for a physical, you may get a cursory little da-da-da-da-da-da from your doctor. The dentist will actually, because they tend to feel that they're responsible for the head and the neck, they'll give a really nice feel. I don't know, for some reason, I'm really ticklish there, but I'm not ticklish anywhere else. When she starts doing that, I usually start getting the giggles. And she's always supposed to stop it. So if you actually, if you, there's your larynx, you can feel it. And then as you feel down, here's your sternocleidomastoid, sternocleidomastoideus, if you use the Latin name. You then feel this mushy stuff right there. That's your thyroid, right there. Just a little bit bumpy, just a tad, and that's your thyroid, essentially. So if you take the thyroid and make a little slice of it, you'll discover the thyroid is filled with little spheres of cells. And there's this filigree of connective tissue and other cells that, in which those spheres are embedded. And these spheres are called thyroid follicles. Thyroid follicles. Now the spheres, it turns out, are hollow-ish. Hollow-ish because there's not cells inside. Instead, there is a colloid material made by the follicle cells. And the follicle cells make thyroxine, the thyroid hormone. And so here, the color on that is just horrific. Here are these spheres. You can see the spheres here like this. And I hope you can see the cells that outline. Those are follicle cells. And there's a blood vessel, obviously. But here are these little spheres. Those are the follicles. Now, in between the spheres, you have other cells. Those cells lie in between, and they're called C cells. C as in cut, as in cardboard, as in crackers, as in Clemens, as in, yeah, I said your name. Cat, cat, as in whatever, C cells. Those cells are called C cells because they make the hormone calcitonin. Calcitonin. And you can get tumors of the thyroid that are C cell tumors of the thyroid. Now, let's take one of these little follicles, let's turn it into a cartoon and blow it up and take a look at it, shall we? And here's what this little thing looks like here. So the follicle cells are bipolar cells. They have an apical side that surrounds the central cavity, otherwise known as a lumen. A lumen. And that lumen is filled with a colloid that you can see here. The colloid is a fluid that contains a protein secreted by the follicle cells called thyroglobulin. Thyroglobulin. Follicle cells make a ton of thyroglobulin, punch it into that lumen with liquid and salts and what have you, and that forms a colloid. It's called a colloid because it's very thick. Very thick. Thyroglobulin is a large glycoprotein. So it gets secreted into the lumen by the follicle cells, gets stored in the colloid. Now the basolateral side are in contact with blood vessels. And on the basolateral side, there is a sodium iodide symporter. Sodium iodide symporter. Can I erase this? So let's make the follicle cell kind of bluish. Looks like a crooked cell. So we have the blood over here. Come on, blood. Shut you off, did I? And we have over here these are sodium iodide symporters. Mr. Lepard, what does symporter tell you? Does the transport go in opposite directions or the same direction? Same direction. So you're going to take sodium inside the cell, is it high or low? Low, very low, because you're pumping it out constantly. So you're going to take sodium and iodide ion, and you're going to bring it into the cell, just like that. The iodide is then pumped into the colloid through a ion transporter called Endocrine. And it does this by exchanging iodide for chloride, which is a nice even exchange because the chloride is also negatively charged. Now, once it's in the colloid, the iodide gets oxidized by the enzyme thyroperoxidase. That changes it into an iodine atom. Iodine is very reactive. You don't generate this any other place because it's really reactive. And it will undergo reaction with the thyroglobulin. Specifically, it will interact with the amino acid tyrosine. That is on the thyroglobulin. Now, if the tyrosine residue is attacked by only one iodine atom, it's known as a monoiodotyrosine, or MIT. If it's attacked by two, you have a diiodotyrosine, or a DIT. And these molecules, as you can see there, are linked together by the thyroperoxidase. The follicle cells will then gobble up the thyroglobulin by endocytosis. They fuse it with a lysosome, it gets degraded, and then the tyrosine with the iodine is now liberated, and that is your thyroid hormone. If you have two iodines attached, that molecule is called thyroxine. If there's one, iodine is called and these tyrosines are actually linked together. So there's two of them together. So this one is going to have 4 iodines on it. This one will have 3 because the way these things get linked together. As you can see here, the endocytosis of the thyroglobulin that is stimulated by thyroid stimulating hormone. Who makes thyroid stimulating hormone? The anterior pituitary. That's why this hormone is also called thyrotropin. Thyrotropin. The other thing TSH does to the thyroid is it has a trophic effect on the thyroid, causes it to grow. So without thyrotropin, the thyroid will shrink and wither. All right, so you take these two, you link them together, you link MIT and DIT, you get triiodothyronine, also known as T3. You link DIT and DIT together, you get tetraiodothyronine. You can't link MIT and MIT together. The enzyme won't do that. So it needs either a MIT and a DIT and a DIT. And so I guess you could say T4 is DIT squared or something like that. Anyway, they stay bound to thyroglobulin. When they get taken up, the lysosome breaks them down, then they get released and they're carried then by carrier proteins in the plasma. This globulin is called TBG, thyroxine binding globulin. They also bind to other proteins like albumin and another protein called transerythrin. This acts as a reservoir of thyroid hormone. This is the reason why, if you have to have your thyroid taken out, you don't start seeing symptoms except months after it was done, because you have this reservoir of thyroid hormone in your body. Also, what happens if your liver doesn't make enough of these proteins in the blood to carry the thyroid hormone? Now, you won't have that reservoir, you'll just have lots of thyroid hormone, and you're going to get the effects of too much thyroid hormone. Because your thyroid is making this amount of thyroid hormone, but there's no reservoir of it. And the parafollicular cells, otherwise known as C cells, make calcitonin. Said that already. Okay, that kind of goes through what I said already. They secrete iodine from the blood, get in the colloid, the thyroperoxidase attaches it to the thyroglobulin, and then takes it up. Well, it links the converted tyrosines together. A MIT and a DIT gives you a iodothyronine. A DIT and a DIT gives you a thyroxine, so on and so forth, blah, blah, blah. And yeah, here's the structure of these. So you could see here, if you put your biochemistry glasses on, that looks like tyrosine. And this is tyrosine essentially without all this, but it's linked to the alcohol group found in the tyrosine. This one, thyroxine, has 4 iodines, triiodothyronine has 3, T3 and T4. And yeah, that uptake and secretion is stimulated by TSH. The TSH receptor, by the way, is a G protein coupled receptor. That's just a cartoon showing you what all happened. Maybe I should have led with that. Well, then you wouldn't have endured my disgusting artwork. Yeah, there it is. All right, any questions on this process? That's how you make it. What does it do now? Okay. Once inside the cell, T4 gets converted to T3 by an enzyme called deiodinase. It's actually called 5' deiodinase, but that's another story. T3 will then bind to the receptors. The receptors are found in the nucleus. The thyroid hormone receptor is a member of the steroid binding family of transcription factors. Oh, but wait a minute, you say. These aren't steroids. You're right, they're not. But they signal through a protein that's a member of that steroid binding superfamily. This protein, the thyroid receptor, is a gene repressor. It represses transcription of genes. When it's bound by T3, it now becomes an activator of gene expression. And interestingly, in order to work, this receptor has to link together with the retinoic acid receptor. Retinoic acid is a derivative of vitamin A. And that's why vitamin A deficiencies can affect metabolism. Because vitamin A is required, vitamin A derivatives, are required for the activity of thyroid hormone. So this activates gene expression. What does it activate? It activates genes responsible for basal metabolism, the basal metabolic rate. So some of you can go outside without a coat on. In fact, I spied the baseball team one fine day, and a couple of guys are out there in shorts playing in 47-degree weather. They obviously have a high basal metabolism. Some of you can do that. I can't do that. And if you ever have had the amusement of watching Chuck White and me going for a run, you'll notice I have 14 layers on. Chuck is running in shirt sleeves and shorts in 30-degree weather. I have the metabolism of a mole. He has the metabolism of a tree shrew. He has a very high basal metabolism. If any of you have seen Dr. White eat, he can eat me under the table 3 times over. And he'll never show it because he has a high basal metabolism. I do not. I walk past the bakery, the fumes from the bakery get into my pores and cause me to gain weight. I have a low basal metabolism, runs in my family. This sort of thing is affected by genetics, but let's say you adapt. You might notice, and as it gets colder, you get more hungry because you're burning more calories. Your basal metabolic rate responding to what? The thyroid hormone. The thyroid hormone. Sorry? Yeah, it's called the caloric effect of food. You may notice that in the DC. You start eating a lunch, and all of a sudden you need to take your coat off. Your body starts to absorb calories, and you start to get warmer. It's a caloric effect of food. It's very well documented. In fact, If you take your temperature before you eat, and then eat and then take your temperature again, you'll notice it's gone up. Based on the way you scan, I'm going to bet you burn calories very quickly. What you eat, you probably burn really fast. Well, I'm betting you burn it quickly. Okay. Now, thyroid hormone will also activate the sympathetic nervous system. And it will increase cardiac output, increase respiratory rate, and increase mental alertness. In fact, did you know one of the things you're supposed to do as a psychiatrist, if your patient comes in with MDD, major depressive disorder, one of the first things you're supposed to check is their thyroid hormone level. Because thyroid hormone levels are linked to mood. And low thyroid levels can be linked to depression. And in fact, thyroid hormone is adjuvant treatment for bipolar depression, a very difficult type of depression to treat. Both the thyroid and the adrenal glands are subject to negative feedback. As thyroid hormone levels increase in the blood, they feed back upon the pituitary to stop making TSH. Same thing with the adrenal glands from the cortex. They feed back on the pituitary to stop making ACTH. So these are both are subject to negative feedback cycle. If you don't get enough iodine on the diet, your body makes more and more TSH, but you don't make enough thyroid, thyroxine, that causes the thyroid to grow. That can what's called a goiter. And an iodine deficiency goiter is common in places where you don't have enough iodine in the diet, where people eat diets of polished rice or cassava or something like that. This is virtually unknown in developed countries because of iodized salt. Another source of iodine would be kelp. Kelp is a very good source of iodine. You can get kelp as a supplement. Some say it helps you lose weight. I don't buy it, but that's what some people say. That's a good question. I think it's based, there's some foods that are very good sources of iodine. Fish being the big one, of course. Some people eat more than enough fish, eating tuna or cold water fish, salmon, just getting a filet of fish sandwich at McDonald's, which I don't recommend, by the way, would be enough iodine really to serve you for almost a month. For kids, of course, they're going to need more because thyroxine is so important for a growing individual. I think it really would depend on your diet. Looking at someone like yourself, Meredith, I'm guessing you have a very good diet because athletes just usually pay attention to that. My guess is no, it probably wouldn't affect you. For someone with a lousy diet, it might. It might. So it's difficult to answer that based on just the average American diet. Other things can inhibit TSH release. Somatostatin, rising levels of glucocorticoids, sex hormones, excessively high level iodine, these can all inhibit TSH release as well. And this shows you the negative feedback that you get, and that's why you get the growth of goiter. Low iodine in the infant can cause problems because the thyroid actually comes online about the 5th or 6th week of development. And that thyroxine is very important in the development of the brain, the eyes, and several other tissues, joints, muscles. And children with poorly developed thyroids will have a condition called cretinism. And one of the first things you look at if you are a OB, look at the tongue. A baby with cretinism will have a tongue that just protrudes out like that, and that's evidence of poor muscle tone. You'll also see thickened facial features and mental challenges usually as well. That cannot be fixed by giving the baby exogenous thyroxine. Now, during adulthood, hypothyroidism or mixed edema can be fixed by giving synthroid, levothyroxine, that sort of thing. So the symptoms will be symptoms of low metabolism, weight gain, lethargy, low voice, things like that, hair loss, what have you. Whereas too much thyroid activity will lead to things like high blood pressure and high heart rate, excessive sweating, bulging of the eyes in very severe cases. And Graves' disease is a condition where the immune system makes an antibody against the TSH receptor. So you get this constant illicit activation of the thyroid. And in cases like that, you just have to take the thyroid out, or usually burn it out by means of radioactive iodine. And then the patient will be dependent on exogenous thyroxine. All right, we're out of time. We'll get into the parathyroids and the calcium balance on Wednesday. There was a request to move the exam to, what was it, Monday, did you say? Was that just Jessica being Jessica, or just everyone? Jessica was just being the messenger, as she often is. Okay. The exam is moved to Monday. Monday, and the chapters will be, it was 1, 3, 4, 5 last time. This will be 6, 7, 8, 9. Oh gosh, do we want to do 10? 5 chapters. Oh, that's too much. Let's just do 6, 7, 8, 9. 6, 7, 8, 9. Okay, guys, the test was moved. I hope you got that.
Yeah, we got that. Thank you.
Okay. Okay, Jacob, stay well, okay?
Yeah, thanks. You too.
Okay, ciao.